Welcome back to the deep dive. This is where we take the weight of those heavy sources off your shoulders. We distill the critical insights, and we give you the knowledge you need, fast and very thoroughly.
And today we are really immersing ourselves in a comprehensive and I would say vital area of nursing.
It really is. We're looking at pediatric and maternal-child nursing, specifically Chapter 54, which focuses on the child with an intellectual disability or developmental disability.
This is truly foundational material. I mean, for anyone training in or practicing pediatric care, understanding this chapter is just absolutely critical for safe and effective practice.
It's not just standard protocols, is it?
No, not at all.
No.
When you encounter a child with an intellectual disability or ID or a developmental disability, DD, you realize very quickly these conditions demand more.
More how?
They require specialized, highly individualized care plans, intensive early intervention, and maybe most importantly, comprehensive, long-term family support.
And the nursing role is just immense.
It's huge. You have to be an active participant in assessing genotypes, in gathering a thorough three-generation genogram, recognizing the subtle signs of developmental delays, and then acting as that primary resource for families.
The person who helps them access all the services.
Exactly. The services that are tailored to maximize that child's development within their specific cultural and social context.
That sets the stage perfectly.
Yeah.
So our mission today is to unpack the source material step by step. We'll cover key definitions, explore the genetics that, underpin these conditions.
And we'll deep dive into specific disorders like Down syndrome, Fragile X, autism spectrum disorders.
And then we'll wrap up with the essential clinical assessments and nursing interventions that you absolutely have to master. But before we jump into the science, there's a really critical shift in language we have to talk about first.
Yes, and language here is power. It really impacts perception. The sources are very clear about highlighting the shift away from the outdated and frankly stigmatizing term mental retardation, or MER.
Which has been replaced.
It's been replaced by the scientifically more accurate and respectful term intellectual disability, or ID. And this shift was formalized in the U.S. through the Individuals with Disabilities Education Act, IDEA, back in 2010.
And it's not just about reducing stigma, right? It's more than that.
It is. It's about a better clinical understanding of the nature of the condition itself.
Okay, so let's unpack this. Starting with the fundamental science the chapter introduces. Let's get into the genetics and genomics context, which is really the root cause for so many of these conditions.
Right. To really get the origin, we have to start at the molecular level. So the human genome is this vast, complete set of DNA instructions. It's the blueprint for life.
And within that blueprint,
Within that, we look at the genotype, which refers to the small variations in specific parts of those DNA sequences. Think of the genotype as the specific coding.
and the phenotype is the result.
Exactly.
So the phenotype is what we can actually observe, the physical stuff, like eye color or height.
That's it. The phenotype is the observable representation of the underlying genotype. The things that cause the problems we're discussing today are mutations, small DNA changes involving, say, deletion, addition, or recopying of sequences.
And even a small change can have a huge effect.
A huge one. Most small mutations are benign, but when they happen in critical areas, they can create enormous negative effects on intellectual ability, physical development, and maturation. And that's what results in intellectual and developmental disabilities.
And that connects right back to nursing, doesn't it? This is why getting that detailed three-generation family history, that genogram, isn't just an academic exercise.
It's not academic at all.
So how often does a detailed genogram actually reveal a manageable risk instead of just a fixed diagnosis?
It's vital because it helps us identify recurrence risk, especially for X-linked conditions like Fragile X syndrome. But it also helps us spot non-genetic but still preventable risks. For instance, if a maternal history points to maybe an unknown exposure to a teratogen, we can counsel the family immediately for future pregnancies.
So you're using genomics to prevent, predict, and plan.
Exactly, to plan care based on biological risks.
So once we identify that biological cause, we have to pivot to function. And the chapter makes a really good point about moving beyond just relying on a standardized IQ score,
Yes.
especially in kids with communication or language disabilities, where those tests might not really reflect their ability.
That is such a critical clinical point. We really rely on two much more functional metrics: mental age and functional age.
Okay, so break those down. Mental age.
Mental age tells the caregiver what conceptual level of understanding is required. So if a patient, regardless of their chronological age, say they're 18, has a mental age of 5, the nurse's explanations have to be simple, specific, and totally concrete.
And if their mental age is 12?
Then you can start to introduce more abstract or complex concepts about their care. It totally dictates your teaching strategy.
And functional age, then, that shifts the focus from cognition to, well, practicality.
Precisely. Functional age refers to the level of adaptive functioning, so how well the child copes and performs activities of daily living, or ADLs, their communication, and essential social skills.
So the main therapeutic goal is maximizing that adaptive function.
It is, and what's really fascinating here is a potential disconnect. A child with a relatively low mental age can still achieve really high levels of independence and adaptive functioning
Oh,
through intensive support and skill training. And realizing this helps us set realistic, empowering goals for their independence, not just intellectual benchmarks.
so when we get to the formal definition of intellectual impairment, or ID, we have to include both of those dimensions.
Correct. Intellectual impairment is clinically defined as a significant limitation in both intellectual capacity, often an IQ below 70-75, and limitations in adaptive behavior.
That dual limitation is key.
It is. It's what distinguishes a global cognitive deficit from, say, a specific sensory deficit like isolated hearing loss or a purely emotional disability. And you have to remember, for it to be classified as an intellectual disability, the onset has to originate before the age of 18.
Okay, now let's widen the scope a bit to the umbrella term, developmental disability, or DD.
So DD is the broader term, and its adoption was actually a major political and legislative strategy. It encompasses ID, specific sensory deficits, orthopedic problems, cerebral palsy, and autism spectrum disorders.
And bringing all those together was strategic.
It was. Uniting these diverse conditions under the DD umbrella provided the collective legislative power they needed to secure comprehensive policy recognition and funding for services. This all culminated in the Developmental Disabilities Assistance and Bill of Rights Act of 2000.
That legislative move created a very, very strict legal bar. What exactly does the legal definition of DDD require?
And this definition isn't just a clinical guideline. It sets a very high legal bar for getting lifelong support. The sources specify 5 requirements.
Yeah.
First, the disability has to be severe and chronic. Second, it has to be attributable to a mental or physical impairment, or both. Third, it has to be present before the individual turns 22. Fourth, it has to be likely to continue indefinitely.
And the last one.
And this is the critical one. It has to cause substantial functional limitations in 3 or more major life areas.
Like what kind of areas?
Things like self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and economic self-sufficiency.
Given that legal definition, how does that BD umbrella status practically mandate the services a child receives, especially with school?
Well, that legal status, primarily through the Individuals with Disabilities Education Act, or IDEA of 1997, it mandates the Individualized Education Plan, the IEP.
Which is a legally required written plan.
Exactly. Outlining all the specialized instruction, related services, and supports the public school system has to provide, and the school nurse is absolutely essential in this process.
They do more than just sign off on it.
Oh, much more. They participate in the IEP evaluations, they offer expert medical advice on necessary classroom adaptations, how to manage medical conditions during the school day, and they ensure medical services like medication administration or catheterization are provided safely and effectively.
So the nurse is the medical bridge between the family and the school.
That's a perfect way to put it.
Shifting to the child's broader health profile, the chapter talks about a high rate of comorbidity. These disorders rarely exist in a vacuum.
That's a major clinical challenge. IDs and DDs frequently coexist. For example, a really high percentage of children diagnosed with autism also meet the criteria for intellectual impairment.
And beyond that primary diagnosis.
Beyond that, these children are also at a significantly elevated risk for secondary psychosocial disorders. Think of a teenager with high-functioning Asperger's syndrome. They are often extremely vulnerable to depression and anxiety because of their difficulty navigating complex social interactions.
Just how high is that prevalence of psychiatric comorbidity?
The statistics are concerning. The prevalence can reach up to 60 or even 70% in adults with DD. It's a bit lower, but still substantial, in the pediatric and adolescent population.
And what are the most common diagnoses?
The most frequent accompanying diagnoses are things like disruptive behavioral disorders, depression, and sometimes atypical psychosis. And this high comorbidity suggests that the neurological conditions causing the ID or DD also directly affect the brain regions responsible for emotional and behavioral regulation.
That connection between high family stress and the increased risk for abuse is deeply concerning. It really underscores why early intervention isn't just medical, it's a critical safety issue.
It is a strong, persistent correlation that nurses have to recognize. Developmental disorders increase the risk for child abuse, neglect, and maltreatment.
And the reasons are complicated.
They're multifaceted. The sources cite the intense and chronic stress that caregivers experience, feelings of isolation from insufficient or non-existent supportive services, and sadly, professional prejudice.
What do you mean by that?
Where parents feel judged or misunderstood by healthcare providers who just don't have specific knowledge about the child's complex needs, mitigating these factors through strong nursing advocacy and support systems is just essential to family safety. So moving from etiology to intervention, the entire diagnostic landscape is really focused on one thing: early identification.
The earlier the better.
Always. The evaluation can happen prenatally, it can happen neonatally if risk factors are present, or later when parents or providers notice significant delays in milestones.
And why the rush?
Because early identification opens the door to early intensive intervention treatment plans. And that offers the greatest opportunity to maximize the child's long-term potential and adaptive function.
And the formal screening process is where nurses become the key gatekeepers. The American Academy of Pediatrics, the AAP, sets some pretty rigorous guidelines here.
Absolutely. The AAP recommends formal developmental surveillance at every single well-child visit throughout infancy and early childhood.
Every single one.
Every single one. And furthermore, specific formal developmental screening should be conducted on all children at 3 standard intervals: 9 months, 18 months, and 30 months.
And a lot of these disorders aren't formally diagnosed until school age, right? When academic failure becomes an issue.
That's often the case, which is why routine assessment using tools like the Ages and Stages questionnaire, the ACE-Q, is our best method for early detection.
The diagnostic table in the chapter is a clinical goldmine. It details everything from routine screens to high-tech imaging. Let's zero in on the 2 tests with the highest immediate safety consequences. We can start with vision and hearing.
Vision and hearing tests are completely non-negotiable. The statistics show that children with Down syndrome, for example, have a very high prevalence of issues.
How high?
40 to 45% have refractive errors or cataracts, and 70 to 80% have hearing defects, often chronic serous otitis media.
And there's a critical clinical detail here for children with autism or pervasive developmental disorders.
There is. They may appear to have defective hearing because of their lack of response or social engagement, even if their hearing function is objectively normal. This makes formal objective testing just crucial. For vision tests, the nurse needs to explain the pupil dilation process and make sure the child has appropriate protective eyewear afterwards.
Thyroid studies are another non-negotiable screen, specifically T4 levels. Given that thyroid ranges vary so much by age, what's the clinical risk if we miss hypothyroidism in a child with Down syndrome?
Missing hypothyroidism can significantly compound the existing intellectual impairment. And it's a treatable condition, so the key here isn't just getting the number, but treating it immediately to optimize neurodevelopment and slow any decline.
So you have to use the right chart.
You have to compare the serum thyroxine ranges against age-specific normal values. And the crucial nursing implication is a procedure alert. These blood serum tests must not be performed within 7 days of a radionuclide scan because of interference.
We talked about measuring function beyond just IQ, but the assessment still relies on standardized tools. What are the key adaptive behavior scales and IQ tests being used?
Well, these tests provide a baseline and measure deviation from the mean. And ideally, they assess skills within 1 standard deviation of the average. Adaptive behavior scales, like the AMR Adaptive Behavior Scale or the Denver Developmental Screening Test 2, they focus on language, motor, social, and self-care skills.
And the IQ tests.
Those include the Bailey Scales for birth to 3 years, the Stanford-Binet Scale, and the Wechsler Intelligence Scale for children, or the WISC-3. And the nurse's role here is often preparation, explaining the test, making sure the child is calm and rested, and helping the family understand how the results are going to inform the care plan.
Okay, now let's discuss bone röntgenography. This one carries a major safety alert.
It does. This assesses bone plates and joint spaces, but its most critical indication is for children with Down syndrome because of the risk of atlantoaxial instability, or AAI.
And what is that exactly?
It's a malformation or laxity at the C1 and C2 vertebrae. If this subluxation or dislocation occurs, it can severely damage the spinal cord.
So the nursing implication is profound.
It is. The child must remain absolutely motionless during the study, and this is the big one. Cervical spine radiographs are mandatory for all children with DS at a young age, specifically before they participate in any strenuous activity, contact sports, or activities that involve hyperflexion of the neck. It's a non-negotiable safety check.
That detail on the pre-sports X-ray is one of those clinical priorities nurses can just never forget. Okay, let's move to brain imaging sonography, CT, MRI, and PT, which get more and more complex.
Right, so brain sonography, or ultrasound, is the least invasive. It's indicated for microcephaly, macrocephaly, or a family history of hydrocephaly. The child just needs to be lying supine.
And then CT and MRI.
These are indicated for impaired development, CNS malformations, tumors, or subdural hematomas.
Yep.
And they're significantly more involved.
The child has to be perfectly still.
Absolutely motionless. And an MRI can take up to an hour. So sedation or physical restraint is often necessary, which requires specialized nursing prep and monitoring. For the MRI, all metal and magnetic objects have to be strictly removed. For the CT scan, a contrast medium is typically used, which requires informed consent from the parents.
And finally, positron emission tomography, or PE scan.
A PET scan compares cerebral brain flow and metabolic changes, and is often used to localize seizure foci that might not show up on an MRI. Nursing implications here include getting informed consent, administering required sedation, and potentially limiting oral fluids before the procedure.
And making sure the child voids beforehand.
Crucial, to prevent unnecessary delays. And in many cases, a parent can stay with the child for comfort. The amount of meticulous prep required for these imaging studies ensures accuracy and safety, making the nurse's role really central to the whole process.
That comprehensive diagnostic process really shows just how many variables the nurse has to manage to get an accurate diagnosis and then establish a safe plan of care.
So when we synthesize the causes of IDs and pervasive developmental disorders, or PDDs, we find a truly multifactorial etiology. It's complex.
It's not just one thing.
Not at all. Causes can range from 6 genetic mutations and chromosomal changes to the prenatal environment like maternal substance abuse or infection, to congenital factors, or even factors from early childhood, things like trauma, poisoning, or a severe lack of stimulation.
And even with all that research, we often don't know the cause.
It's sobering. A specific cause remains unknown in nearly half of all diagnosed cases.
So let's break down the causes by severity. I think that's useful for risk assessment. Where do we draw the line between factors that lead to a mild disability versus a severe one?
The sources categorize them pretty clearly based on the primary drivers. Mild disability is often linked to environmental or neonatal alterations.
Okay, like what?
This includes intrauterine infections like rubella, HIV, or toxoplasmosis, exposure to environmental toxins like in fetal alcohol spectrum disorder, and neonatal conditions like prematurity, low birth weight, hyperbilirubinemia, or hypoglycemia. These kids generally have a better prognosis and respond well to early intervention.
And a severe disability.
A severe disability is typically attributed to major fixed biologic or genetic causes or severe acquired conditions.
So that's where we see things like Down syndrome.
Exactly. Biologic or genetic causes include inborn errors of metabolism, specific hereditary syndromes, and chromosomal alterations like Down syndrome and Fragile X syndrome. In fact, Fragile X is highlighted as the single leading inherited cause of intellectual impairment.
And what about acquired conditions?
Acquired childhood conditions involve major central nervous system insults, meningitis, encephalitis, severe poisoning like from lead, head trauma, or cardiorespiratory arrest leading to anoxia.
And psychosocial problems can also lead to severe delays.
They can. Things like extreme psychosocial deprivation, inadequate health care, and severe parental mental health issues like psychosis.
So the cardinal sign that alerts any caregiver to an underlying issue is still that delayed achievement of developmental milestones.
Right.
But the associated behaviors are often what bring the family to the clinic, and those behaviors vary dramatically by severity.
They really do. For children with a mild intellectual disability, the associated problems tend to be more internal and psychosocial. Profound self-esteem issues, social isolation, depression, and loneliness.
And for a severe impairment.
For a severe impairment, the behavioral issues often become external, very challenging, and they require constant, high-level supervision. We're talking about self-injury like head banging or biting, fecal smearing, destroying clothing, severe temper tantrums, and disrobing in public. Managing these requires immediate behavioral intervention plans.
And beyond the behaviors, these children carry a heavier overall medical load because of associated physical disabilities.
Precisely. IDs and DDs frequently coexist with comorbidities like cerebral palsy, vision and hearing deficits, seizure disorders, and persistent feeding problems.
And it's crucial to connect those dots clinically.
It is. The presence of associated disabilities significantly increases the risk for other acute illnesses. For example, if a child has both an intellectual impairment and cerebral palsy, the impaired motor control often leads to gastroesophageal reflux, or GERD.
Which dramatically increases their risk for aspiration pneumonia.
Right. So the nurse's job is focused on preventing that entire chain of events.
So therapeutic management requires a highly multidisciplinary approach, often a surgical one, targeted at fixing or managing those comorbidities.
And it demands strong advocacy from the nurse. General strategies include prioritizing adequate prenatal care, which is a Healthy People 2020 objective, and maximizing the child's placement in regular inclusive school programs.
And the medical strategies are aggressive.
Very. Treating chronic infections, correcting structural deformities through cardiac or GI surgery, or providing orthopedic interventions like splinting for hypotonic joints.
To structure all that support, the chapter provides clear categories based on IQ and adaptive skills, which dictates the level of support required. This seems fundamental for care planning.
It is. This system establishes realistic expectations for independence. So for a mild intellectual disability with an IQ of 50-70, they require minimal support.
Meaning they can be pretty independent.
Yes, they have slight developmental delays, but they achieve a functional age where they can communicate well, care for themselves, and often maintain independent adult relationships. Their education should focus heavily on vocational and self-maintenance skills.
Next is moderate intellectual disability.
That's an IQ of 36-49, requiring limited to moderate support. Here, delays in motor and speech are noticeable by preschool. Cognitively, they achieve an elementary school level. As adults, they often perform unskilled work but require a supervised setting, like a group home.
Then severe intellectual disability.
IQ of 20-35, requiring daily extensive support. There is a marked and very early delay in motor skills and self-help skills. Expressive speech is limited. They require constant supervision.
And finally, profound.
Profound intellectual disability is an IQ below 20-25. This requires 24-hour support. These individuals often have severe physical limitations, maybe only primitive speech, and usually require complete provision of all activities of daily living.
That clarity helps nurses avoid encouraging unrealistic expectations for either the child or the family. Let's return to safety, which the chapter really stresses is a primary nursing function, especially given the cognitive deficits.
Children who are intellectually impaired are inherently less capable of perceiving and managing environmental hazards. It's due to impaired executive functioning, judgment, and motor skills. So injuries are statistically more common. We have to teach safety proactively, and we have to recognize that our teaching method has to fundamentally change.
The safety table in the chapter provides excellent examples of how that education needs to be prolonged and highly repeated, evolving as the child develops.
Yes, we have to fundamentally alter our concept of practice and repetition. For the kitchen, for example, safety education starts in the preschool years with basic prevention. Don't touch the hot stove, avoid ingesting toxins.
And you contrast that with a high schooler.
Right, a high schooler who, depending on their mental age, may be learning simple cooking safety and emergency precautions like turning off the water heater or knowing how to call for help.
And the same applies to outdoor safety.
Absolutely. A preschooler with ID needs prolonged repetitive teaching on staying within yard boundaries and avoiding ingesting non-food items like berries. An elementary schooler needs focused lessons on stranger safety, bicycle rules, and water safety, all delivered with frequent verbal and visual reminders, demonstrations, and vastly more practice time than a typical peer would need to achieve mastery.
So the nursing intervention is the tailored, patient, and persistent adaptation of teaching methods to the child's mental age. All right, let's dedicate a specific segment now to Down syndrome, or trisomy 21. It's the most common chromosomal disorder and a critical focus for pediatric nurses.
It really is.
Yeah.
Down syndrome occurs in about 1 in 691 births in the U.S., and it's the most frequent cause of moderate to severe intellectual impairment. 95% of cases result from trisomy 21.
The presence of a third copy of chromosome 21.
Right, the presence of all or part of a third copy. And this happens due to non-disjunction, which is the failure of the paired chromosomes to separate normally during meiosis, often during egg formation.
And what about the remaining 5%? What causes those cases?
That 5% is split between two other causes, translocation and mosaic DS. In translocation, part of chromosome 21 is fused to another chromosome, most often chromosome 14.
And that form is unique.
It is, because it is not associated with maternal age, and it can be hereditary, which requires specific genetic counseling.
In mosaic DS.
Mosaic DS is the rarest. This is where some cells in the body are normal and some have trisomy 21.
Yeah.
Because of that mixture of cell lines, children with mosaic DS often have a milder presentation.
We know maternal age is the single most significant predictor of risk for the common trisomy 21, but the chapter clarifies something that's often misinterpreted.
That's right. Because most women giving birth are under 35, the absolute number of children with DS born to younger mothers is actually higher, even though the risk percentage rises dramatically with maternal age.
Moving to the pathophysiology, how do 3 copies of chromosome 21 fundamentally alter development?
The triplication causes developmental alterations, where malformations result from incomplete rather than strictly abnormal embryogenesis.
So that explains the characteristic structural malformations like the heart defects.
Exactly, like atrioventricular canal defects in the heart. And then as the individual ages, critical alterations in neurotransmitters, specifically the cholinergic system, are thought to be responsible for the premature aging process and the onset of Alzheimer-type dementia.
Let's review the distinctive phenotype, which is so classic it often leads to a diagnosis immediately at birth.
The physical presentation is very recognizable. Craniofacial features include brachycephaly, which is a short head, a flat facial profile, inner epicanthal folds that give the eyes an upward slant, a wide and flat nasal bridge, and a narrow, high-arched palate.
They also often have a protruding tongue.
Yes, and that, combined with the small oral cavity, contributes to feeding difficulties. Body features include short stature, short, broad hands, and the presence of a singular transverse palmar crease, the simian crease.
And they often exhibit hyperextensibility of joints.
Yes, with generalized hypotonicity of muscles, which contributes to poor posture and motor delays.
And that hypotonicity leads us right back to that critical musculoskeletal abnormality.
The atlantoaxial instability, AAI, at the C1-C2 vertebrae. This is the major safety threat. The laxity of the ligaments there puts them at risk for spinal cord compression if the neck is hyperflexed or extended aggressively.
Which is why that safety alert we discussed about pre-sports x-rays is so unbelievably crucial.
You can't be overstated.
Clinically, what is the expected intellectual trajectory for a child with DS?
Most individuals fall into the mild, so an IQ of 50-70, to moderate, an IQ of 35-50, range of impairment. However, a major concern for long-term care is the decline in intellectual abilities and adaptive skills with age.
Alzheimer-type dementia is a near certainty.
It is. The prevalence is estimated at 25% for those over 35, and most individuals over 60 will exhibit significant symptoms of thinking and memory problems.
The sheer number of associated medical conditions detailed in Box 54.4 just demands aggressive, structured monitoring by the nursing staff.
It really does. In the neonatal period, the nurse has to aggressively monitor for severe cardiac defects, specifically endocardial cushion defects and tetralogy of Fallot, as well as GI malformations like tracheoesophageal fistula or Hirschsprung disease.
And throughout childhood?
Throughout childhood, we monitor for obesity, chronic serous otitis media, thyroid dysfunction, and an increased risk for acute leukemias. The complexity of managing these comorbidities is just immense.
So what does the active management in the nursing care plan look like for this population?
Well, beyond the initial diagnosis via chromosomal analysis, therapeutic management involves regular screening, early intervention programs, and active medical management, including potential surgery for cardiac, GI, or craniofacial issues.
And we have to reinforce that cardinal safety rule.
Neck radiography must be performed before the child participates in any strenuous recreational or athletic activity due to the AAI risk, period.
In terms of ongoing assessment, how do we support the family through that initial diagnosis and the subsequent care?
Well, the assessment starts with a meticulous physical exam and screen, but nurses also have to assess the child's typical coping patterns. Children with DS thrive on routine and consistency.
So you need to know their language.
You need to identify their specific words for body functions to avoid confusion and assess their motor skills and any self-stimulating behaviors. Crucially, nurses provide vital emotional support. Many parents report profound disappointment and anger stemming from professional prejudice, being told the birth is a tragedy.
So the nurse has to counter that narrative.
Immediately, by being supportive, identifying community resources, and encouraging bonding by focusing on the child's specific strengths and endearing features.
And what about specific feeding and hospitalization interventions?
Feeding assistance is critical early on. The hypotonia and a poor suck can make breastfeeding difficult, so the nurse has to patiently help the family explore options, whether that's specialized bottles, adaptive utensils, or nutritional counseling.
And when they're hospitalized, the quality alert applies.
Absolutely. We have to keep the child's routine waking, sleeping, eating schedules as close to home as possible. We use a detailed written care plan to ensure consistency among staff, and limiting the number of staff members interacting with the child minimizes adjustment demands.
And you're also actively supporting self-care and independence.
Always. Looking for signs of readiness for tasks like zipping or buttoning, even if adaptive tools are required due to poor dexterity.
All right, let's transition to a highly complex set of specific developmental disorders. We'll start with conditions of known genetic cause: Fragile X syndrome and Rett syndrome.
Fragile X syndrome, or FXS, is recognized as the most common inherited cause of cognitive impairment. It's second only to Down syndrome overall.
It's caused by a defect in a single gene.
That's right, the FMR1 gene, which is located on the X chromosome, that makes it a sex-linked inheritance pattern. So males are generally more severely affected, about 1 in 5,000, because they lack that protective second X chromosome. Transmission occurs only through carrier mothers.
What's actually happening in the pathology of Fragile X?
The pathology involves an unstable mutation, specifically excessive repetitions of the CGG DNA sequence. This affects the production of the FMR1 protein, which is essential for normal brain development.
And it affects multiple domains.
It does, categorized across 6 areas: intellectual, physical, social-emotional, speech-language, sensory, and comorbid disorders.
Can you describe the most notable physical and social manifestations that nurses should recognize?
Physically, the child often presents with a long, narrow face, prominent or large ears, lowered epicanthal folds, flat feet, and hyperextensible fingers. Post-puberty, the defining physical characteristic in males is macroorchidism, which is enlarged testicles.
And socially,
Behaviorally,
we see distinctive patterns: gaze aversion, difficulty maintaining direct eye contact, peer relationship deficits linked to facial recognition difficulties, and frequent disruptive behaviors like temper tantrums, self-injury, and repetitive hand-biting.
they also exhibit high rates of autism-like behaviors.
Yes, like hand flapping. And they often present with hyperkinetic behaviors and tactile defensiveness.
Given that complexity, what's the best therapeutic management strategy?
Well, there's no cure right now, but aggressive management focuses on early intervention, special education, vocational programs, and behavioral management. Speech and language therapy has to begin very early.
And for the motor deficits? For motor planning and coordination deficits, the intervention of choice is sensory-motor integration therapy. It helps the child process sensory information more effectively. Medications are only used to manage the comorbid symptoms, things like hyperactivity, anxiety, or seizures. Nursing care includes targeted behavioral interventions and, critically, genetic counseling for the entire family.
Okay, next up, Rett syndrome. This is a profound developmental disorder that is almost exclusively female.
Rett syndrome is a fascinating but devastating condition. It affects about 1 in 10,000 females, and it's related to a mutation in the MECP2 gene on the X chromosome.
And its hallmark is the timeline.
Yes, an initial period of relatively normal development, followed by a sudden devastating regression of symptoms between 6 and 18 months of age. This involves the loss of developed social and intellectual skills, seizures, and severe physical disabilities.
The manifestations include that hallmark hand movement.
The hallmark stereotyped, repetitive, hand-wringing or hand-washing movements. And it's so important to stress to families that Rett syndrome is considered a DD, not a degenerative disorder. The neurons are not destroyed, and notably, it is the only autism spectrum disorder for which the genetic cause is currently known.
Now we shift from fixed genetic causes to conditions related entirely to environmental alterations, specifically fetal alcohol spectrum disorder, or FASD.
FASD is caused by maternal alcohol consumption during pregnancy, and the sources emphatically state that no safe level or time of consumption has ever been established.
None.
None. The incidence is estimated between 0.2 to 1.5 per 1,000 live births, but this is likely grossly underestimated because of significant underreporting.
And the pathology is severe.
Very. The alcohol and its metabolite, acetaldehyde, cross the placenta, disrupt protein synthesis, and result in decreased brain cell numbers, generalized brain malformation, and permanently diminished intelligence.
What are the specific measurable diagnostic criteria nurses need to confirm a diagnosis, beyond generalized growth deficiency and microcephaly?
The ZDC criteria require either confirmation of alcohol exposure, though it's not mandatory for the diagnosis, coupled with 3 defining features.
Okay, what are they?
First, the characteristic facial abnormalities. These include short palpebral fissures, so small eye openings, a smooth philtrum, which is the groove between the nose and upper lip, and a thin vermilion border, or a thin upper lip.
Those features are very specific.
They are, because those facial structures develop during specific alcohol-vulnerable phases of embryonic development. The second feature is prenatal or postnatal growth deficiency, and the third is central nervous system abnormalities.
Such as a small head circumference.
Right, a head circumference at or below the 10th percentile, structural brain abnormalities, or unexplained motor deficits or seizures.
How does the nurse support the infant with FASD, especially since feeding and attachment can be so challenging?
The assessment has to focus on microcephaly, hypotonia, tremulousness, and persistent feeding difficulties. Interventions require meticulous monitoring of weight and INO.
You have to get creative with feeding.
You have to patiently try various feeding strategies, different nipples, specialized positioning, small and frequent feeds, to ensure successful caloric intake. And because these infants are often difficult to soothe and feed, the nurse plays a crucial role in promoting early parent-infant attachment, which can be really strained.
So counseling is also required.
Yes, to help parents cope with the diagnosis, manage potential guilt, and maintain realistic expectations for the child's future.
Our final environmental and psychosocial consideration is failure to thrive, or FTT. And the source defines this not as a diagnosis, but as a cluster of symptoms.
That's right. FTT describes a child whose weight or rate of weight gain falls significantly below that of comparable aged children. They often appear dramatically smaller and malnourished. The etiology is either organic, so due to a physiological defect, or non-organic, which is much more common and multifactorial.
Non-organic FTT results from an interplay of factors.
Yes. The child's temperament, severe parental stress, maternal emotional states like depression, and critical socio-demographic factors. The source highlights that FTT is disproportionately seen in low-income families, given the pervasive issue of child poverty and food insufficiency.
What are the telltale behavioral and psychosocial manifestations of FTT that nurses should be looking for?
Physically, you see weight below the 5th percentile, delayed milestones, decreased muscle mass, and signs of cachexia. Behaviorally and psychosocially, these children often exhibit avoidance of eye contact or physical touch, a characteristic intense watchfulness, sleep disturbances, and a lack of age-appropriate stranger anxiety.
Their affect can appear disturbed.
Yes, apathetic or wary. And they often engage in repetitive self-stimulating behaviors like rocking, head banging, or intense sucking, which indicates a lack of satisfying external stimulation.
Management is focused on aggressive nutritional therapy.
It is, aiming for a growth rate 2 to 3 times the average. This often requires caloric enrichment, concentrating formula up to 24 calories per ounce, although nurses have to monitor carefully, as higher concentrations risk dehydration and diarrhea. Family therapy and extensive parenting classes are also standard components of care.
What kind of assessment provides the most value for non-organic FTT?
A thorough psychosocial history is essential. The nurse has to inquire about income, food availability, storage capacity, existing stress factors, and any underlying family psychopathologic conditions like maternal depression or substance abuse.
Most critically, you have to assess the parent-infant interactions.
Yes, how the child is held, the feeding dynamic, the degree of eye contact, and the overall synchrony between them. If the child is hospitalized, the nursing intervention focuses on providing a consistent caregiver to build trust, role modeling appropriate interactions, and building parental confidence by focusing on achieving small, realistic goals.
Finally, we turn to autism spectrum disorders, or ASDs. This is a complex grouping that ranges from the severe, classic autism to milder forms like Asperger's syndrome.
And the prevalence is staggering. It continues to be identified at high rates, approximately 1 in 68 children in the U.S. The core features are pervasive and lifelong. Atypical development, profound difficulty developing social relationships, disordered communication, and stereotypes interests or behaviors.
And symptoms are usually noticeable by age 3.
Yes, and the AAP strongly recommends formal screening specifically for ASD, using tools like the MCHAT at 18 and 24 months.
Let's start with the high-functioning end of the spectrum, Asperger's syndrome.
Children with Asperger's syndrome typically present with normal or even advanced intellectual and language development. Their primary deficits are purely social and emotional. They have a marked inability to understand social cues and norms.
Their language is fluent, but fixated.
It's fluent, but often highly fixated on their own narrow interests, without any regard for the listener's engagement. They frequently desire peer relationships, and they're friendly, but their rigidity, emotional dysregulation, motor clumsiness, and organizational problems make maintaining those relationships incredibly difficult.
And classic autism, the most severe form.
This is severely incapacitating and lifelong. It's defined by qualitative impairment in communication, social skills, and behavior, coupled with abnormal, often overwhelming, responses to sensations. About 75% of children diagnosed with classic autism also present with concurrent intellectual impairment.
Before we detail the manifestations, let's address the persistent public discourse around etiology. The source firmly rejects the historical psychogenic view, correct?
Oh, absolutely. Decades of controlled studies have thoroughly dismissed the outdated, harmful concept that autism stems from family dysfunction or refrigerator mothers.
So what are the current theories?
They focus heavily on genetics and specific environmental risk factors, like maternal rubella or anoxia during birth. Crucially, the sources emphasize that multiple large-scale epidemiologic studies have definitively established no correlation between the occurrence of autism and the MMR vaccine or vaccines preserved with thimerosal.
What does the cutting-edge genetic research suggest about the origin?
Researchers are now moving toward a theory of subtypes. They've identified inherited genetic mutations, which they call familial autism, but they've also found a tenfold higher prevalence of tiny, rare, spontaneous mutations, sporadic autism, in children who have the disorder but no family history.
So autism is not a single entity.
It suggests that autism is a spectrum of conditions that may share neurobiological pathways with other emotional and developmental disorders.
Let's detail the primary behavioral manifestations based on the DSM criteria, which nurses use to assess severity.
Right, so we look for a triad of impairment. First, social impairment. This is defined by a marked lack of awareness of the existence or feelings of others, an inability to seek comfort when distressed. They may not even show pain when hurt, profound impairment in peer relationships, and that characteristic pattern of playing alone.
Second is language impairment.
This includes the absence or impairment of verbal communication, often presenting with abnormal volume, pitch, or rate, or the use of echolalia, which is repeating words or phrases. Nonverbal communication is markedly abnormal, lacking gestures or expressive facial signals.
They often become preoccupied with the subject out of context.
Exactly. And the third part of the triad is the restricted behavioral repertoire. This requires the presence of at least two criteria.
Like what?
Stereotyped body movements, so hand flapping or rocking. A persistent abnormal preoccupation with object characteristics, like smell or taste, or an intense attachment to peculiar objects, like a piece of string. Marked distress over even minor environmental changes.
A light being turned on.
Yes. An unreasonable insistence on non-functional routines, or a marked restriction in the range of interests, like repeatedly aligning objects.
It's so important to distinguish between classic autism and other conditions like ID or schizophrenia. Table 54.2 provides a clear differential diagnosis framework.
This table is essential for avoiding misdiagnosis. So, autism versus intellectual disability. Autism often presents with a peaked skill profile, some high, some low skills, a significant lack of imitative skills, and non-social behaviors.
Whereas ID has a flat skill profile.
Exactly. And they retain basic imitation and gesturing skills and typically initiate social contact, even if their language is limited.
And autism versus schizophrenia.
Autism has an onset before 54 months with no remissions, and hallucinations or delusions are rare. Schizophrenia onset is typically during adolescence or pubescence, involves remissions and relapses, and hallucinations, delusions, and thought disorder are common features.
Finally, let's discuss management and the crucial nursing care required for maintaining stability, especially during acute stress or hospitalization.
Early identification and intensive behavioral treatment are essential. Therapeutic management focuses on creating a stable, interactive environment and using behavioral methods to replace those problematic, stereotypical behaviors with normal ones. Lifelong treatment and supervision are required, focusing on safety-preventing self-injurious behaviors and promoting functional communication, often through picture boards or keyboards.
The nursing quality alert in the chapter focuses heavily on maintaining routine. How crucial is that consistency in a hospital setting?
It is the single most critical nursing intervention. Children with autism are highly vulnerable to stress caused by even minor environmental changes, which leads to frustration and decreased coping. The nurse has to work meticulously with the family to document the child's specific routines, habits, and preferences.
The order of self-care, specific environmental cues?
Even preferred objects, and then adhere to them strictly. To ensure consistency, nursing staff must be limited to as few individuals as possible.
How does the nurse communicate effectively when social cues and language may be so profoundly impaired?
First, you have to identify the child's specific style. Is it sign language, pictures, or limited verbalization? It's vital to recognize that a lack of eye contact does not signify a lack of awareness or attention.
You have to allow extra time for responses.
Prolonged time. The child might answer after several minutes of delay. They often understand far more receptive language than they can express.
And the ongoing safety imperative.
Safety against self-injury, particularly self-mutilation like headbanging, requires meticulous observation, especially at night. Physical measures like a helmet or side rolls may be necessary. And during hospitalization, the presence of a parent or an older sibling is almost always necessary, as they are the primary experts on the child's routines and nonverbal signs of discomfort.
So the nurse's continuous evaluation focuses on reducing those adjustment demands to prevent behaviors that signal anxiety and stress. Hashtag tag tag outro.
Okay, to synthesize the most important nursing takeaways from this deep dive into intellectual and developmental disabilities, I think there are 5 key points.
Let's hear them.
First, early screening is mandatory. Adhering to the AAP guidelines for developmental surveillance and formal screening at 9, 18, and 30 months is just non-negotiable for maximizing developmental potential.
Okay, number 2.
Second, the definition guides practice. Recognizing ID as a limitation in both intellectual capacity and adaptive functioning, that functional age dictates our goals toward maximizing independence.
Number 3.
Third, advocacy is core nursing practice. We have to actively support the family through the complex grief and coping process, provide robust emotional support against professional prejudice, and connect them with long-term specific resources.
And number 4.
Fourth, care must be hyper-individualized. Maintaining strict routines, minimizing staff changes, and understanding unique communication styles are the key quality alerts, especially in high-stress environments like the hospital.
And the last one.
Fifth, safety is condition-specific. Nurses have to tailor safety measures to the specific diagnosis, from ensuring pre-sports neck radiography for atlantaxial instability and Down syndrome, to intense observation and physical protection against self-mutilation in severe ID or ASD.
This entire chapter emphasizes complexity and vulnerability, and it prepares you for one of the most challenging and, I think, rewarding areas of pediatric care. So here's something to think about. Given the established high prevalence of comorbidity, particularly between psychosocial disorders like anxiety and depression and these various developmental disorders, what additional psychosocial screening tools should be integrated into routine pediatric visits beyond just standard developmental checks to proactively address mental health needs? That's something to actively think about as you integrate this knowledge into your clinical practice.
A really important question.
Thank you for joining us for this deep dive. Thank you from the Deep Dive team.